For my presentation, I chose rheumatoid arthritis and the medication sulfasalazine. Rheumatoid arthritis, or RA, is a systematic inflammatory disease that causes pain due to inflammation of the synovial joints. Sulfapyridine is a metabolite of sulfasalazine that is believed to inhibit the pro-inflammatory signaling pathways that causes RA. The picture on the slide can be shown to demonstrate the inflammation of the joints. The red highlighted areas are where symptoms of RA would usually appear. There are three main pathways in RA. NF-KB, or nuclear factor Kb, controls the expression of several genes that regulate immune responses: cell growth and proliferation, survival and apoptosis, stress response, and embryogenesis and development of various stimuli. MAPK, or nitrogen-activated protein kinesis, is an embryonic angiogenesis that acts as a hypoxia-sensitive repressor of vascular endothelial growth factor expression. Finally, JAK-STAT, or Janus kinesis/signal transducer and activator of transcriptions, which transfer signals from the cell membrane receptors to the nucleus. RA is an autoimmune disorder that consists of B cells and T cells. These cells can be found in the synovium and peripheral blood. Macrophages can be found in the synovial joints and regulate the secretion of pro-inflammatory cytokines and enzymes. The top picture is a T cell and the bottom picture is a B cell. B cells create antibodies. These are called B cell lymphocytes. Antibodies created by the B cells will bind to the pathogens and foreign substances to neutralize them. B cells are made of bone marrow. T cells are made in the bone marrow. T cells protect the body from infections. T cells are called T lymphocytes, and they help protect the body by sending signals to the immune system to wipe out and kill infected cells. T cells are made in the bone marrow. Cytokines are small secreted proteins released by cells that specifically affect cell interactions and communications. Cytokines are produced by the peripheral nerve tissue. This slide is a visual aid to show what B cells and T cells do in the joints. The B cells are making antibodies to protect the body from foreign outside cells. The T cells are destroying the body's cells that have already been infected. In the case of RA, the joints break down because the T cells are forced to attack them. This slide further elaborates how T cells and B cells lead to the destruction of joints while trying to fight RA. It better shows the outcome of each cell's path. There are multiple signaling pathways to recognize pain association with RA. These pathways include the JAK signaling pathway, the Notch signaling pathway, the MAPK signaling pathway, the WNT signaling pathway, the PI3K signaling pathway, and the SYNK signaling pathway. These pathways are responsible for pain receptors and potential targets for drug discovery. This slide serves as a visual aid to the pathway described in the previous slide. This is the order in which the signals travel through the pathways to signal inflammation in the brain. A patient may experience some forms of onset, such as polyarthritis onset, which usually affects smaller joints in the hands and feet before spreading to larger joints. The polymyalgia onset, which usually causes elderly patients to experience stiffness in the pelvic girdle and shoulders. Palindromic onset is a recurring episodes of pain and swelling and redness affecting one or more joints at a time, lasting a day or two. Systematic onset is a non-focal complaint such as weight loss, depression, fatigue, or fever. It may be related to an extra-auricular feature such as sclerosis or vasculitis. Persistent monoarthritis is a persistent arthritis affecting a single large joint such as a knee, shoulder, ankle, or wrist. Signs and symptoms of RA include pain, stiffness, swelling, redness, and decreased range of motion. The picture shows a hip and leg and what areas RA would affect. The red highlighted areas of this diagram indicate where you would most likely feel the symptoms due to where the joints lay in comparison. RA can be difficult to diagnose early on due to a lack of physical evidence. However, the doctor will look for redness and swelling in joints. People with RA may have an elevated erythrocyte sedimentation rate, or ESR, or C-reactive protein, CRP, shown in blood work. Imaging scans of your body, such as X-rays and MRIs, can also be helpful when trying to pinpoint the location and severity of the progression of your RA. This slide shows an X-ray of a healthy hand versus a hand affected by RA. In the hand affected, you can see where the labeled signs of bone erosion and shiftage caused by the destruction and loss of joint tissue. This is a rather severe case. This slide shows an MRI scan of a healthy knee versus a knee affected by RA. The MRI shows a buildup of fluid produced by the body to try and combat the inflammation caused by the breakdown of joints and bone erosion in the knee. Seropositive RA symptoms are lifelong and can either improve or flare up at random times. Multiple joints will be affected and usually will be affected symmetrically. Seropositive means a positive result in anti-CCP, or anticyclic cerulinated peptide, which is when you have high levels of rheumatoid factors, or RF, found in blood tests. With seronegative RA, symptoms are less severe and unpredictable. This is based more on symptoms such as stiffness, swelling, pain, and redness. Negative refers to a lack of anti-CCP or RF found in blood test. Diseases that mimic include psoriatic arthritis, osteoarthritis, lupus, viral arthritis, reactive arthritis, arthritis of IBD, Lyme arthritis, and palindromic rheumatism. RA can be distinguished by which joints the pain is found in, although only sometimes RA is more likely to be found in smaller joints than larger ones. In addition, RA is symmetric primarily in your body. RA can be diagnosed with blood tests and scans of your body. RA is a very unpredictable disease. However, 4 stages have been discovered. Stage 1, early RA, where few symptoms can be observed, but you may experience stiffness. Stage 2, moderate RA, where inflammation of the synovium may cause joint damage. You may experience pain and loss of range of motion. Stage 3, severe RA, where the damage of the joints and cartilage between bones has worn away. Pain, swelling, and weakness of mobility will be experienced. Stage 4, end stage, where the joints no longer work. Joints fuse, which is called alkalosis. This may take years or decades to reach, and people with well-maintained RA may never see this stage. Long-term, unmanaged RA can lead to a variety of issues, including disability and joint disfigurement, eye complications, skin symptoms, neck and spine problems, heart disease, blood vessel disease, blood cell problems, lung issues, osteoporosis, depression, and anxiety. You may be at higher risk for RA if you are affected by family history. You might be more likely to develop RA if it runs in your immediate family, such as a parent or sibling. Age and risk of arthritis usually increase with age and sex. Women are more likely to develop RA than men are. If you have previously damaged or injured a joint, you may be at more risk of developing arthritis. You also may be at more risk if you struggle with obesity. Carrying excess weight stresses your joints and can put you at more risk for arthritis. Studies have shown that there is evidence of capillary damage, edema, and vascular congestion just 6 weeks into the disease. It can be found throughout affected areas. The synovium is a primary spot of inflammation, and when left untreated, can be victim to irreversible damage. The synovium is also called the synovial membrane. I have shown this picture on this slide. You can see a visual of the synovium membrane. Here you can see where the anti-CCP mentioned on slide 17 and the presence of molecules are that cause inflammation shown in RA. RA is a chronic disease that causes your body to attack healthy cells. RA usually affects your joints. Sulfasalazine is delivered orally, partially broken down in the jejunum, and then delivered to the colon, where it can be properly absorbed to block inflammatory signals. Symptoms of damage caused by RA include pain and aching in more than one joint, stiffness in more than one joint, tenderness and swelling in more than one joint. The same symptoms will be mirrored on both sides of your body: weight loss, fever, fatigue and tiredness, and weakness. RA pain is processed by pain signals sent to the peripheral spinal and supraspinal pain pathways. Although sulfasalazine has been used to treat RA for decades, its mechanisms have yet to be discovered, and it is still being studied. Currently, medications are being used to target specific cells to stop the inflammation signals sent through them, thus resulting in arthritis. Currently, we are using this cell-targeting theory to try and cure RA. However, this is still a theory and has yet to be demonstrated on a working large scale. RA is a disease that specifically affects the synovial joints. This disease is most common in women and elderly. There is no cure for RA. Bone loss is a pathological hallmark of RA. Sulfasalazine is a class of medication called anti-inflammatory drugs. Sulfasalazine works by reducing inflammation inside the body. Sulfasalazine comes as regular and delayed-release tablets. Delayed release releases the medication in the intestine to prevent irritation to the stomach and to allow the medication to work in the intestine. For the treatment of rheumatoid arthritis, sulfasalazine delayed-release tablets are usually taken twice a day, evenly spaced doses throughout the day. Sulfasalazine is indicated to treat chronic inflammatory diseases such as RA in children, RA in adults, and ulcerative colitis. Sulfasalazine can also have off-label uses treating ankylosing spondylitis, mild to moderately active Crohn's disease, psoriasis, and psoriatic arthritis. 3 forms of sulfasalazine may act in RA. It is still being determined which leads to the benefits of RA, although the 5-ASA moiety is mainly unabsorbed. Sulfasalazine acts as a folate antagonist. Folate antagonist is a drug that stops cells from using folic acid to make DNA. On this slide, I have attached the pictures of the different chemical formulas of all 3 medications found in sulfasalazine. Sulfasalazine inhibits the binding of TNF-alpha to its receptors. TNF-alpha is what causes the inflammation of specific cells. By blocking the TNF-alpha from attaching to its intended target, it prevents inflammation and neutralizes the RA effects temporarily. Tumor necrosis factor alpha, or TNF-alpha, is a cytokine that has multiplying effects on various cell types. It has been identified as a significant regulator of inflammatory responses and is known to be involved in the pathogenesis of some inflammatory and autoimmune diseases. It is functionally known to trigger a series of various inflammatory molecules, including other cytokines and chemokines. In RA, TNF-alpha activates synovial fibroblast, which causes the overproduction of caspins and MMP. The breakdown of collagen and proteoglycan follows MMP matrix metaproteinases, MMPs, are extracellular enzymes, and cathepins are the most abundant lysosome proteases. TNF-alpha also activates osteoclasts, leading to synovial fibroblasts, which result in joint erosion. This diagram shows TNF-alpha and its functions in RA. The diagram shows how TNF-alpha combined with other chemicals in the body to provide a various amount of symptoms, such as the ones described on the previous slide. This slide shows the chemical reaction of TNF-alpha in a simpler and, in my opinion, more mentally manageable way. TNF-alpha, along with synovial fibroblasts and osteoclasts, create an abundance of cathepins, which in turn leads to the breakdown of collagens and proteoglycan. This cartilage and bone will eventually, then cartilage and bone, and eventually joints. The exact mechanism of sulfasalazine has yet to be fully understood. However, the following immunomodulatory effects of sulfasalazine and its metabolites have been suggested as an underlying mechanism of their actions. Sulfasalazine inhibits transcription factor nuclear factor kappa B, eliminating the transcription of TNF-alpha. Sulfasalazine inhibits TNF-alpha expression. It inhibits the osteoclast formation, inducing the conversion of adenine nucleotides to adenosine. Sulfasalazine inhibits leukocyte acclimation. Sulfasalazine and its metabolites sulfpyridine and 5-aminosalic acid inhibit B cell functions and not T cell functions and suppress the production of IgM and IgG. Sulfapyridine inhibits the secretion of inflammatory cytokines and monocytes. The pro-inflammatory NF-κB signaling pathways inhibits the phosphorylate activation of adenosine monophosphate activated protein kinesis by 5-aminosalic OA. The FDA approved sulfasalazine for treating patients with rheumatoid arthritis. It is cheap and easy to administer and lacks teratogenicity compared to other disease-modifying arthritic drugs. Teratogenicity is an ability to cause defects in a developing fetus. Sulfasalazine indicates for patients with rheumatoid arthritis who may not have responded adequately to salicylates and other non-steroidal anti-inflammatory drugs. Clinical trials have proven that sulfasalazine significantly reduces disease activities, whether used alone or in combination. RA is a chronic inflammatory disease in which TNF-alpha receptors attack the cells, causing joint swelling, pain, and damage. If left untreated, RA can cause serious and permanent damage, and in severe cases lead to death. There are 4 stages of RA, which progressing in pain and severity. Sulfasalazine may help maintain RA symptoms by blocking TNF-alpha and reducing inflammation. Thank you.